And the question we asked with the ISCHEMIA-CKD trial is if you have a patient with moderate ischemia and advanced CKD, is there a benefit of adding cardiac catheterization and revascularization on top of optimal medical therapy? And the reason we are conducting this is, CKD is a growing population. There is everywhere around the world there is increase in prevalence of diabetes, obesity, and consequently we see a lot of these patients with CKD. But one thing we have been increasingly recognizing is many of the cardiovascular trials, in fact the majority, excluded patients with advanced CKD. So we just don't know how to best manage these patients. So far we've been using data from non-CKD cohorts and assuming that that may apply to CKD cohort. And this is one of the reasons we said we need a dedicated trial to answer this question, because if you just go back and look at the prior contemporary trials of looking at invasive versus conservative strategy, they either not enrolled those patients or included only a few of them. For example, Courage trial had only 16 patients, and FAME2 trial had 20 patients, and BARI2D trial excluded patients with creatinine greater than 2. So this was designed as a multi-center international randomized controlled trial. It was funded by NHLBI. We screened patients who had moderate or severe ischemia and advanced CKD. And advanced CKD was defined as patients on dialysis, or if you have a GFR less than 30. And patients were randomized 1-to-1 to either an invasive strategy, which was optimal medical therapy and cath and revascularization if feasible, or to a conservative strategy of optimal medical therapy alone, preserving cath and revascularization only if you fail optimal medical therapy. The key inclusion criteria were at least moderate ischemia as determined by the site, so it's either moderate or severe ischemia, and also having advanced CKD, the definition which I just said. The key exclusions were if you have left main disease, or if the EF is less than 30%, or ACS within the last 2 months, or really symptomatic patients. Those were the major exclusion criteria. So we are reporting the major clinical outcomes. So the primary endpoint was a composite of death or MI. What we noted was the rates in the conservative strategy was pretty high, 36% at 3 years. Interestingly, the rates in the invasive strategy was very similar, so there was no evidence of a statistical difference between the invasive and conservative strategy. Similarly, we noticed that there was no difference between the two strategies for the major secondary endpoint. It was also true for many of the components of the secondary endpoint. One of the things that we did notice was for the outcome of stroke, there was significant higher rate of stroke in invasive when compared to the conservative strategy. And we are still exploring to figure out where the signal is coming from, but what we know as of now is the procedure-related strokes were very few. It was only one patient in the invasive, one in the conservative, so it seems to be that the stroke risk we see in the trial is driven by non-procedure-related stroke. First of all, if you go to the quality of life of the CKD trial, what we've noticed is, first of all, over close to 50% of the randomized patients in the CKD trial did not have symptoms. So it was basically a less symptomatic group of patients. The quality of life benefit in the CKD trial was actually less impressive than that of the main trial. In the main ischemia trial, we found that invasive strategy significantly improves angina and quality of life when compared to conservative strategy. And in that trial, we found that the benefit is actually durable up to 4 years of the trial. We did not see a similar benefit in the CKD trial. There was a benefit at 3 months, but then it waned off. So to me, that's the major difference between the two trials. In other words, the main ischemia trial showed a significant quality of life, angina benefit with invasives compared to conservative. We didn't notice that in the CKD trial. In terms of the clinical outcomes, they were largely similar in the sense that in the ischemia trial, there wasn't, overall, there was no difference between invasive and conservative for the primary endpoint and the secondary endpoints. In the main trial, we did notice that invasive strategy increased procedural MIs and reduced spontaneous MIs. In the CKD trial, we noticed similar trends, but it did not reach statistical significance. So there is a lot of alignment in how we are seeing the results in both the trials. I think, for the first time we have an answer to this really sick group of patients. I mean, we know that these patients at 3 years, the mortality rate was 25%. So 1 in 4 are dying within 3 years. So something needs to be done, but the answer is very clear from our trial that an invasive strategy does not prolong life. So there are some of the unanswered questions. One of them includes, if you're truly very symptomatic, is there a benefit? There is potentially a small magnitude of benefit which needs to be investigated. One of the other things that we found in the trial was there was an heterogeneity of treatment based on whether the patient had moderate versus severe ischemia. So in other words, if you had severe ischemia, the results tended to favor invasive strategy, and if you had moderate ischemia, tended to favor the conservative strategy. So this is another hypothesis generating that needs to be explored in the future.